Good afternoon. My name is Paul Wax. I'm the Executive Director of the American College of Medical Toxicology, and I'd like to welcome you all to our webinar series entitled The Medical and Public Health Considerations of COVID-19. Today we'll have three presentations. Our plenary presentation will be on risk communication in unusual times. That will be followed by a short presentation on the media, pandemic, and health behavior. And we just added a third short presentation, given the timeliness of this topic, which is the COVID-19 mink situation in Denmark. Next slide. I'd like to thank our webinar series partners for helping to promote our webinar series. Much appreciated. Next slide. And I'd like to thank all of our veterans. Today is Veterans Day, and we owe them a great deal of gratitude and appreciation. Next slide. Our webinar will be recorded and will be posted to our website. You can see the URL at the top. Recording will be posted in approximately 48 hours, and you'll all get an email notification with the webinar link. You can also look at any of our previous webinars. We've been doing this since late March of 2020 and have quite a series of important webinars up on our website now for free learning for free on-demand access. Next slide. There will be a Q&A at the end of the webinar, so please type your questions into the Q&A function during the webinar or into the chat function. We'll be screening the questions and try to get to as many of your questions as possible. Given the three presentations today, we may go a few minutes after 4 p.m. Eastern to get to all the questions, depending on the numbers that's in the queue. Next slide. I'd like to thank my co-moderator, Dr. Ziad Kazi. Dr. Kazi is a board member of the American College of Medical Toxicology and president of the Middle East and North African Clinical Toxicology Association and an associate professor at Emory University School of Medicine. Dr. Kazi will be introducing our speakers today. Next slide. Finally, I'd like to also introduce a close colleague of ours, Dr. Charles McKay. Dr. McKay is the past president of the American College of Medical Toxicology, and he will be helping out with the moderation today. At this point, I'd like to turn the microphone over to Dr. Kazi for the introduction of our first speaker.
Thank you so much, Dr. Wax. It's my pleasure to introduce Dr. Julie Fisher, who is a senior technical advisor on global health with CRDF Global. ACMT and MINATOX have collaborated closely with CRDF Global on toxicological and chemical security activities around the world, particularly in India and the Middle East, North Africa region. And it's been a pleasure to work with her preparing this webinar today. Dr. Fisher is going to talk about risk communications in unusual times, and I promise you that you're going to really enjoy the knowledge that she will share with us related to this important topic. Dr. Fisher?
Thank you so much for the introduction and for the invitation to speak here. I'm very pleased and proud to be here today, and I appreciate all of your time and patience. CRDF Global, for those of you who may not be familiar with the organization, is a nonprofit based in Arlington, Virginia, with offices in Amman, Jordan, and Kyiv in the Ukraine, which focuses on science-based solutions for global health and security challenges. We have a long history in working in non-proliferation, particularly chemical and biological threats. And we have since built on that foundation to look at border health, emergency operations and emergency management and health emergencies, and to look at capacity building for diagnostic testing and disease surveillance. Part of that emergency management is risk communications. Often in a public health event, risk communications is the first and sometimes the only tool immediately available. But I will be talking about what is happening in terms of risk communications in our environment and how that environment shapes what tools we have available and what beliefs people hold when they come to encounters with the medical and public health sectors. So one of the messages that CDC uses in their crisis and emergency risk communications materials is that the right message at the right time from the right person can save lives. And certainly during emergencies, again, with risk communications is the tool that we have for public health, getting people the information that they need to make the best decisions possible, whether they are healthcare providers, first responders, or members of affected communities, is critical in helping them assess and understand the risks to their health and safety and take protective actions. The three examples here are examples of risk communications failures. The one on the upper left with the flames coming from the platform is actually the Deepwater oil rig disaster. And that was a case in which failure to communicate did cost lives. Specifically, outreach by an engineer to managers who were back on the mainland about whether two pieces of coupling for equipments could be substituted safely for each other within the operating specs of the rig. And the answer was no. But that was not, the question was communicated in a technical way, and the urgency to respond did not get across to management. The memo here is from a very similar case study, one that did not cost lives, but did cost billions of dollars. When the Chicago River burst through a set of faulty valves into freight tunnels that had been dug below the city at the beginning of the 20th century to help deliver coal and other goods downtown. There was a very obvious damaged section of concrete that needed to be replaced at a cost of about $15,000, something that was identified by a city engineer and notified in the memo that you see here to his upper level management. However, because of the way he phrased it, which was quite technical, his upper level management did not perceive it as urgent and did not take action. As a result, the tunnels flooded. Downtown Chicago had to be evacuated for 3 days, and the cost of cleanup ran in the billions of dollars. And finally, the case study that's most relevant to us in health. The bottom left-hand corner is a photo from a press conference that was being held by then Secretary of Environment and Agriculture, John Gummer. What you see is John Gummer encouraging his daughter to eat a hamburger on British television. He was doing so because only a few years earlier, a disease called bovine spongiform encephalopathy, BSE, sometimes called mad cow disease, had been detected in cattle in the UK. Although public health officials and scientists were starting to suspect that there was a risk to human health, the need to protect the British cattle industry without a lot of background risk assessment led the UK government to take steps to communicate the safety of British beef. And this particular press op, in which this was taken before the child began crying at being forced to eat a hamburger on television, while intended to reassure the public, later really backfired when it became apparent that this disease could affect humans. And although the number of cases was less than 200, the communication from health authorities and government authorities that a consumption pattern was safe when it was indeed not undermined public confidence. So, apologies, more sensitive than I thought it would be. So when we think about all of these types of communications, they cover different sorts of risk communications, operational risk communications between members of a single organization or members of a government or of a sector to try to get across decision-making, and risk communications with the public. When we think about risk communications with the public, there are many purposes: raising awareness, encouraging protective behaviors, and helping to inform affected communities so that they can understand hazards and risks, accept or manage those risks, and take protective behaviors. The action of taking protective behaviors can help provide warning to publics so that they are prepared, and help them reduce anxiety or outrage at the threat to their health and safety. Risk communications is not a single set of activities. It happens on a spectrum. On an ongoing basis, when we think about risk communications, it's the multi-directional and real-time exchange of information, which is a change from how this used to be perceived as informing an audience to understanding how risks are assessed and managed. That exchange of information can be among individuals, institutions, and affected communities to encourage the rational analysis of and response to a risk so that those communities are more prepared, they adopt protective behaviors, their understanding is increased, and what has been called defensive pessimism, trying to counter the optimism bias that often lets us convince ourselves that we are really not at risk, despite what we hear or perceive. A more specialized subset of risk communications is crisis communications. After an event or an emergency has already happened, those communications that help describe the specific context and to identify the risks, help explain the interventions so that they are more accepted by the community and thus can reduce harm, both by helping individuals adopt protective behaviors and creating acceptance of public health interventions. And I'm going to talk about that in some case studies. And then finally, after a crisis, risk communications is an ongoing part of the planning cycle, not only to help learn and improve responses for the next event, but to help secure support for rebuilding, repair any damage that has been done during the event through mistrust or miscommunications, and to try and move forward. Ultimately, risk communication strategies are an attempt to get across information from a communicator to a receiver about the type of risk, whether it's from a behavior or an exposure in the environment, and the magnitude. What will happen if no steps are taken? Why is risk communications hard? This is it's hard for a lot of reasons. It's easy to talk about risk communications and difficult to explain ourselves clearly. And one reason is that all of us, I suspect every one of us on this call, has a deep area of technical, medical, or public health expertise. When experts speak, they have been trained to give long, complicated, and logical explanations that support their points with evidence until they finally arrive at the key message. But when people listen, and that includes experts outside of very specific technical fora, we listen for the point, and then we selectively tend to recall the evidence, the reasons, and the explanations that support what we assume is true about that point. So risk communications is hard because for experts, narrowing down to simple communications can be very difficult. And that's one of the reasons that health agencies have invested funding in developing strategic communications processes to try and create a structure, a process, and an understanding about risk communication. This is an example of the Public Health Agency of Canada's dialogue-based strategic risk communications process, which really emphasizes understanding who the stakeholders are, helping to determine what their perceptions of risk, benefits, and trade-offs are of health risks, risk to health and safety, understand what they see as the options, and then develop strategies to try and communicate what options are available. The CDC has a suite of tools around crisis and emergency risk communication, CERC or CERC, that takes into account different sorts of risk communications. And I'm going to begin on the column here that's not in the box, but all the way on the right, just regular risk communications, routine communications on an ongoing basis about potential risks, either from environmental exposures or due to behaviors, and how we think about them in terms of time pressure. That is, we have plenty of time to think about how to do this most effectively, why we do it to empower decision making, and who can talk about it, really anyone who's expert. But if we're talking about crisis and emergency risk communication, then we're talking about unexpected and urgent timing, and the need to not only empower decision making, but to explain and persuade populations to take protective behaviors quickly. And that's part of a rhythm that CDC has developed and advocated in this suite of tools that you have seen in the past few months deployed in response to the COVID-19 pandemic. There is this is a summary of a long process that involves preparing ahead of time with risk communications messages that can be deployed quickly during an event, a quick response to when an event occurs, for example, such as an outbreak, to begin communicating and engaging the community through the expression of empathy, explaining risks, promoting actions, a maintenance phase of continuing to respond to the event, and finally, responding through resolution. These circles here are the way that CDC has chosen to explain who needs what kind of information. So those who are closest to an event, the directly affected communities, the medical community that's responding, public health actors, first responders, they actually need information urgently to maintain safety. But around them is a much larger group of affected people, families, respondents, members of the community who need information on how to keep themselves safe and to protect themselves from becoming affected. And then there's the larger group, the group of observers who have information, who are connected to what is happening at the community level, even at the national or international level, but who are not immediately affected, including decision makers. They are motivated by concern for their safety, and they need information about how to prepare, what they can do, something that's called vicarious rehearsal. Sorry, what you're watching, communications failure in action. Let's try that again. One more time. CDC, ironic, isn't it? In developing these principles of crisis and emergency risk communications, CDC, over the course of experiences that include the response to the anthrax assaults of 2001, followed shortly after that by the emergence of novel highly pathogenic avian influenzas, the 2009 H1N1 influenza pandemic, the Ebola virus disease events that first unrolled in West and Central Africa, and now, of course, we're facing the COVID-19 pandemic. CDC evolved a set of principles that are widely recognized for crisis and emergency risk communications, and they boil down to some very simple principles. Be first. That is, whoever provides the first message has an opportunity to influence ongoing dialogue. Be right. Whoever speaks should be able to speak credibly from a position of technical authority, and should not guess or fill in information that they don't know that will later be proved wrong. Be credible. Again, whoever speaking should be able to be authoritative during crises. Express empathy. That's acknowledging that really we are all affected, and that the people who are most directly affected by an emergency are experiencing distress and possibly loss of safety, loss of security, or even loss of life. Promote action. Give people something to do to protect themselves or to be receptive to public health interventions. And finally, show respect. We've moved from a place in risk communications in which it is assumed that authorities tell people what to do, to authorities acknowledge that we are all bringing different kinds of expertise to the table, and that expertise at the local level is just as valid from a person who is experiencing an exposure and knows how to manage it with local resources as a person is who is speaking from the position of authority. And there are 5 pitfalls that CDC has identified to avoid. Mixed messages from multiple experts. Certainly something that we've all witnessed, the expression of interpretation by multiple scientists, all of whom may bring different kinds of expertise to a question and who may give different messages. Releasing information late, paternalistic attitudes, not countering rumors or myths in real time, and public power struggles and confusion. So what I'm going to do now is move into two case studies. One, the experience in risk communications around the Ebola virus disease epidemics that emerged in West Africa in 2014 through 16, and in the Democratic Republic of the Congo, DRC, in 2018 through this year. And think about, as we go forward, those pitfalls. How are we doing cumulatively as a risk communications function for public health? As I'm sure you all remember, in 2014, in very late 2013, Ebola virus disease spilled over from an animal disease reservoir into the human population in a remote area of Guinea, where the disease spread as a result of weak surveillance and an initial lack of laboratory confirmation to understand what the actual disease was. Spread rapidly, first among health workers and later among networks of household contacts of the initial cases, until it spread widely in the Western African region, leading to more than 28,000 cases and more than 11,000 confirmed deaths, which is doubtless an underreporting, plus a smattering of exported cases elsewhere in sub-Saharan Africa and in countries in Europe and the US. One of the reasons that risk communications is so important is that by communicating operationally with health personnel and others that are actually implementing the response, and by communicating for social and community mobilization, that knowledge about what the risk is, what measures can be taken to ameliorate it, and how those interventions could have an impact allows the communication through formal networks to identify cases of disease, to mobilize public health interventions, to investigate and to prevent further spread of the disease, and allows reporting. So this is a diagram of the key reporting chain during the Ebola response. This is a very abstract version of reporting that was used as a schematic to understand in Sierra Leone, in Liberia, and Guinea. This particular diagram is from Sierra Leone. How local community health workers would identify or local community stakeholders, not even necessarily health workers, would identify cases of suspected Ebola, which would be reported up to the district level, where resources would be mobilized to both provide information back to the community and report those cases up to the national level for response, to the Ministry of Health, to the national government, and finally up to the international level. Every one of these actions depends on risk assessment, people at the community level recognizing the disease risk or disease threat in this case, and on the communication at the operational level so that people know what to do. What are your responsibilities? Where are you reporting? What are you reporting? What is the risk? What steps need to be taken to ameliorate it? And one of the interventions that requires the most risk communications is support for those public health interventions that take place at the community and the household level. This is actually a risk communications tool that CDC put together partway through the international response to the Ebola virus disease outbreak to try to help the public and affected communities specifically understand what contact tracing is and its role in Ebola virus disease response, or the response really to any outbreak. This diagram, which again illustrates how contact tracing works at the community level, shows the progression from a confirmed case of Ebola, a patient receiving care, to the actions that a contact tracer would take to identify contacts, locate them, determine if they have themselves developed any signs or symptoms of disease so that they can be quickly isolated and prevent further transmission of disease to others. And so that, again, people who are exposed and at risk can be quarantined and monitored throughout that quarantine to prevent the transmission of disease to others. Contact tracing depends on trust, pure and simple. It is only, while technology can facilitate it, it is ultimately a case in which the individuals and their families affected by a disease have to share information transparently with a person who's generally a stranger, in the belief that that action will help protect their community. When that trust is lost, it erodes not only the trust in the interventions in the abstract, but the willingness of communities to cooperate with public health interventions. So this is a couple of, I'm just going to list a few lessons that were learned in retrospect about risk communications in the response to the Ebola virus disease outbreak. One is that there was enormous reliance on electronic media for risk communications. And in Sierra Leone, Liberia, and the Republic of Guinea, that was primarily radio when we're talking about electronic media. But what was found is that as opposed to print media, and by print media, we mean traditional media, so either print on a computer or on a phone, or literally on a piece of paper print media. People who got most of their information from print media were more likely to have relatively accurate perceptions and knowledge of the risks posed by Ebola virus disease, the most common symptoms, and the actions that could be taken to protect an individual in a community where Ebola virus disease was spreading. This is a study in which a group of researchers looked at, through a set of surveys, at how members of communities in Sierra Leone had received their information on Ebola virus disease and how it affected their knowledge, attitude, and practices, so CAP survey. What they found was that the more that people had learned, the more likely they were to take effective protective behaviors as opposed to ineffective behaviors that they had learned through misconceptions, such as, for example, saltwater baths are protective against Ebola virus disease, which became a very widespread misconception. Those who got their information from print were more likely to have an accurate sense of how to protect themselves. Those who learned most from electronic media had high awareness, but were very likely to have misconceptions that did not lead them to adopt protective behaviors. And this particular glimpse here is an attempt to address that, the recognition that electronic communications, electronic media are the best mechanism of reaching people, but they needed to be accurate. This is a photo of an HIV/AIDS community mobilizer who was brought in to help give accurate information so that the information, at least going out over radio messages, was reliable and technically sound, even if people don't recall that information with 100% accuracy. Fact-based messaging can be complex and contradictory. Many of us who are technically trained, when confronted with the unknown, have an immediate urge to tell people a lot of facts. One of the first is that the first messages that came out about the Ebola virus disease outbreak in West Africa, the EVD outbreak, always began with Ebola virus disease is caused by a virus. And sometimes it even went into the family of the virus so that people could understand, so that scientists who are describing a virus can categorize how that virus is likely to survive and to spread using their own technical knowledge. But for most people who do not have a technical background, that makes it very difficult to sort through the relevant information and to know what to do with it. A lot of the fact-based messaging that was initially developed by international partners throughout West Africa focused on relatively complex messages, some of which were really difficult to act on in local context, particularly messages that said immediately take yourself to your nearest designated treatment center. If no designated treatment center had been developed or designated, people weren't sure what to even do with the information they'd received, or information that said practice safe burials without any hint of what that meant. Very difficult for people to understand and act on those fact-based messages. And if people hear enough complex and contradictory messages, they tend to tune out essential facts. These are some examples of materials developed later in the EVD West Africa epidemic that gave people actionable messages. And those actionable messages helped turn the tide. One of the key messages to get across is not Ebola is a deadly disease, which I don't know if you could read the small print on one of those previous posters, but that's how it began. Ebola is caused by a virus. Ebola is a deadly disease. It told people what not to do, but it didn't give them any idea that Ebola could be treated successfully or why they would want to take themselves to a treatment unit for care. These risk communications materials that came out later, while completely still accurate, offered more compelling actions that could be taken to protect families and households. And they helped really turn the tide in people's behaviors. This is another set of highly simplified messages developed by the World Health Organization as tiles to be shared through social media that gave people short, actionable facts that were easily understood. Another of the lessons learned is that failure to engage communities leaves room for rumors to grow and spread. This is a diagram of communications management failures that was developed by researchers following the EVD epidemic in West Africa. And what they really looked at was where there is a deficiency in formally developed risk communications materials, or where those materials don't seem relevant to people, they tend to get most of their information from friends and family, either directly or via social media. And the sharing of that information, whether originally from an official source or not, tends to be trusted, and rumors tend to spread and grow. And when communities are not asked about the risks or threats they're facing and how they perceive them, they tend to fill in the gap with their own informal communications and rumors. The costs of miscommunication can be very high. In Guinea, in Liberia, and in Sierra Leone, all had a challenge of being places where there had been instability, prolonged, protracted political conflict, and difficult in trusting governments. That allowed rumors to spread. The impact on public health interventions was pretty dire, particularly at the beginning. This headline, "The Fear of Health Workers Fuels Ebola Crisis in Guinea," poor understanding at the community level of what the public health actors who are coming in to implement Ebola interventions were doing, led people to be very non-cooperative. They did not cooperate with contact tracing. They did not cooperate with quarantine and isolation recommendations, not because people were inherently challenging authority, but because they simply didn't trust what they were being told. And that lack of trust in some cases resulted in violence, with a team of health workers who had arrived near the original epicenter of the outbreak to ironically provide health information from an NGO were actually murdered when they arrived in the village by those who feared that they'd actually come to spread disease and threaten their safety and security. And in other cases, people actually who were concerned about their loved ones being transported by ambulance to Ebola treatment units that were opaque to them, where they could not understand the outcome for their loved ones and often received no word of whether they had survived or died or where they had been buried, rose up violently against health workers. In this case, rioting against Red Cross workers who they accused of introducing Ebola to Guinea. In the last 3 years, we've seen the spread of Ebola virus disease in the Democratic Republic of the Congo, DRC, another country that has been affected by chronic political instability and violence. And the take-home message from there is that where there is no trust in the government, people tend to pass that mistrust on to health authorities, whether they're clinical health care providers or whether they are public health actors who have come in to try and identify cases and isolate them. This is, again, a research paper that looked at institutional trust and misinformation in 2018 to 2019 in North Kivu, the conflict-affected region where most of the cases of Ebola virus disease occurred in the DRC in the last few years. And what they really found was that if you looked at how people felt about trust in their local authorities, in their provincial authorities and their national authorities, trust was very, very low in national level authorities. And they looked at how that correlated to trust in information. They found that people on the whole trusted health professionals much more than they trusted government authorities. But where trust in the government was low, people were far more likely to believe the misinformation that they had heard, such as Ebola doesn't really exist. It's been fabricated for financial gain by external Western parties, that it's that essentially that it is a fiction that was created to destabilize and undermine the region. And again, the cost of that information and mistrust were high. Ebola treatment centers were attacked violently, resulting in the death of a WHO technical expert who was there to help support care. Efforts to actually roll out the vaccine, which is now available as a tool, are hampered because people simply don't trust authorities and are not willing to expose themselves to what they consider a highly questionable vaccine. So let's talk about, just briefly, outside of that extraordinarily catastrophic but localized epidemic, what we've seen around communications during the COVID-19 pandemic. This is a recent headline from Scientific American, which is blunt. COVID misinformation is killing people. And it uses the term infodemic, a term that was actually first used in the 1980s, to talk about the spread of contrasting information about COVID that has become in many ways politically polarized and in some ways simply a source of confusion among people who aren't sure how to best protect themselves and their families. We've learned, again, many of the same lessons that were observed during the Ebola virus disease epidemics that we just discussed. So electronic media are more likely to lead to misconceptions. This is a little bit of just a glimpse from Recode, which is a non-governmental entity that looks at misinformation shared through social media, that looks at retweets of vaccine-related misinformation, and really noticed that during the COVID-19 pandemic, those retweets of vaccine-related misinformation, that is simply facts that are not supported by our best available scientific understanding, are forwarded by members of the public using Twitter. A group of scientists looked at how trust in experts in the media affects people's receptiveness to this kind of information shared over social media. And what they found was that once people had acquired a set of facts that were not accurate, that is, that they had accepted misinformation, it was very difficult to shake those misconceptions. Again, the first information that they heard and accepted became established conceptions for them. Those who had greater trust in medical experts were less likely to accept the misinformation to start with, but once people had accepted something that was not true, they were likely to hang on to those first impressions. And we've certainly seen very contradictory information circulating during the COVID-19 pandemic. This is a quick glimpse from a two-part documentary that was developed with support from funders who are very, frankly, anti-vaccination advocates. The first version was called Plandemic, the second Plandemic Indoctrination, and it's you see the highlighting there of doctor, a set of documentaries that proposes the idea that the COVID-19 pandemic was actually manufactured by Anthony Fauci at NIH and NIAID and his colleagues in the pharmaceutical industry through decades of planning to create a market for pharmaceuticals. The entire thing stands up really very poorly to even the most cursory logical examination. This article from Science is one of many that fact-checked the accuracy of the statements in these documentaries and found that they're really very thinly woven together sets of misrepresentations, but it's really slickly produced. It has all of the hallmarks that we've been trained culturally to expect out of a well-researched documentary. And for many people, the argument seemed as compelling as any other. It was viewed millions of times on Facebook and through links to Instagram and Twitter before those social media companies agreed to take it down in the attempt to remove misinformation during the COVID pandemic. The very removal even fanned the flames of conspiracy that they've been taken down, because obviously, if there's a vast conspiracy, removing the information would be part of it. We've learned, just as we have during EVD, that fact-based messaging can be complex. Trying to communicate to the public about the difference between particles, aerosols, and why wearing a mask was not initially recommended, but subsequently was, and how to do so safely. While it has had an influence on decision makers, it has been generally, has seen a general trend toward the adoption of wearing face coverings to prevent, as a method of source control, to prevent people from infecting others, to prevent people who may be asymptomatically infected really specifically from infecting others. The message has been very difficult to convey, and the reason I wanted to include this graphic, which is from a preprint, is to think about not only how we are conveying fact-based messages in risk communications products deliberately made for the public, but the fact that preprints have become an unprecedented source of information for the media and for decision makers. In a way that allows scientific research and new findings to get to them very quickly, but without the overarching protection of peer review and interpretation by other experts. Where there is no trust in government, there is a lack of trust in health authorities. Polls have shown consistently that Black Americans, in what has been called the Tuskegee effect, the recall of past and terrible misdeeds done in the name of research, are more hesitant to trust in research and to eventually accept vaccine once approved, even though they are among the higher risk groups in many urban areas. And that many Americans are simply suspect of information that is being shared with them by decision makers about the vaccines that are in the pipeline. Where does this disinformation come from? Well, there is actually official state-sponsored disinformation. Governments do invest in the spreading of misinformation, and this is tracked and updated. This report is available online. It was a report by a group in Europe that focused on deliberate disinformation, spread mostly from the governments of Russia and China, mostly targeted at Europe, at Western Europe, with some spillover that carries those messages through social media around the world. But all of these messages are aimed at undermining trust in national authorities about actions to prevent the spread of the pandemic, or treatments and preventive interventions. Once that information is spread, however, it can be taken up and propagated by individuals. And this to me was a really interesting study that came out of the Lazar Lab at the Network Science Institute. Again, all of this data is online, and they actually make all of their raw data available to download. They looked at who shares the links to fake news domains. And I'm going to talk about the definition of fake news in a minute, but spreading information from a number of websites that have been identified as frequently posting information that is not supported by general factual understanding. And what's really interesting is who is propagating this information. According to their research, those who are most likely to propagate and spread links to the websites where information that is either very biased or appears to contradict general scientific and medical understanding can be found, the largest group is older Americans, those 50 to 64 or 65 and up, and there does seem to be some political bias in those who are sharing that information. Whether it's because the sites are biased or because those are people who are simply different kinds of media users is not immediately clear. But it's certainly obvious that people are sharing links to websites that have questionable data. The good news is that so far in the US, as around the world, trust in science and medical professionals remains relatively stable. This is a Pew Research Trust using data from 2019 and 2020. The dark blue line is trust in the scientific community based on a series of questions asked of poll takers, and the lighter blue is trust in the medical community. And while the percentage of US adults who say they have a great deal of confidence in the scientific community and in medicine hovers at somewhere just below 50%, it's still relatively stable. So that was the good news. The bad news is fake news is deeply rooted. This is a report from UNESCO that looked at world trends in freedom of expression and in media development. What they used as the definition of fake news is the deliberate fabrication of what appears to be reliable evidence to explain an event, to explain a risk or a threat that is that unfolds false information but presents it as accurate. And they didn't look at the motivations for that, whether it's politically driven, whether it's driven by economic or market drivers, just at the presentation of information that is misrepresented as factual. That propagation has been, it includes hoaxes, it includes disinformation, and it is really aided by changes in our business models for how the press is funded that have led to a consolidation of press sources and a lack of diversity in local media. It can be exploited by malicious actors who can certainly, with relatively small amounts of resources, spread information quite effectively, whether it's accurate or not. And finally, by low levels of critical thinking and news literacy among the public, which then just leads to a loss of confidence in traditional media and again creates room for rumors. And that really creates a question. What are we going to do moving forward globally and really specifically in the US in terms of acceptance of the public health interventions for COVID-19, most specifically the vaccines that are being produced through public-private sector coordination and funding and are currently being tested in simultaneous phase 2 and phase 3 trials at an unheard of speed. This is a draft slide from the US CDC on the strategy to reinforce confidence in COVID-19 vaccines. Now note, this is not a risk communications tool. This is not messaging for the public. This is the strategy moving forward to reinforce trust, to empower healthcare providers, and to engage communities and individuals. And in the current environment, it's going to be an uphill battle. So, whoops, apologies. Oh. Sorry, I'm trying to go backwards. I am not doing this. It is moving itself forward. Let's try going back. I apologize to everyone who I just spoiled their talk. My apologies. So I just want to very briefly say the question at this point is where we are going to go from here. These are two signs from two different places I've lived. The one on the left, the parking sign, is from my new home community of Washington, D.C., where you often see embodied this kind of warning about the consequences of ignoring parking laws. This is all 100% likely to be true, and also so complex that it's incredibly difficult to figure out how to interpret the guidance that's being given. The second shot here is from my hometown where I grew up. It's posted, these were posted next to a very small one-lane bridge over a body of water. The first sign that was installed gave the useful warning, when bridge overflows, high water exists. Later, someone came in and realized that perhaps more actionable advice was required and added, caution, if high water exists, do not cross. As we think about risk communications and what it means now for the acceptance of the general public and even of technical experts for information on health crises like the COVID pandemic, but moving forward for the daily routine threats posed by unhealthy behaviors and environmental risks. How do we move forward in dealing with this environment where we have a lack of clear pathways to act? So thank you. I appreciate your time. We're going to be moving on to the next of our panelists, and I appreciate your patience.
Thank you so much, Dr. Fisher. This was a comprehensive description of this very important topic. It really gave me a lot of perspective. We've been doing a lot of medical and public health presentations, a lot of medical, clinical topics. This is really enlightening to me, and certainly has a lot of impact on what we've done and what we need to do to overcome this enormous challenge. Thank you again. For our viewers, we will have to go till 4:20 p.m. Apologize ahead of time, but we do want to also have a Q&A session. So we'll ask Dr. Fisher and Dr. Milke to stick around at the end of your update for our third speaker, who's actually in Denmark tonight and is going to give her update later. So our next presentation is actually from Dr. Jad Milke. Dr. Jad Milke is an associate professor of journalism and media studies. He's a chairperson of the Department of Communication Arts and the director of the Institute of Media Research and Training at the Lebanese American University in Beirut, Lebanon. Dr. Milke had conducted some really relevant research in the summer. I think recently in the summer. He'll give us more details on the timeline, but he is kind enough to share with us this, I believe, pre-publication data that is very relevant to the topic today. Dr. Milke?
Thank you, Ziad. I will not have a PowerPoint. I'm going to spare you the agony of a PowerPoint, so you're going to have to stare at a photo that was taken of me 5 years ago. Actually, I'm lying, maybe 10 years ago. Much better than what I look right now. So the study that I'm going to be talking about was conducted by the Institute of Media Research and Training at my university, the Lebanese American University. You can find a full white paper about the findings on our website, imrt.lau.edu.lb. I'll just post the URL here to all the panelists. Maybe somebody can share it with you. The first peer-reviewed publication will actually appear in Health Communication very soon, and I'm going to talk about it today. So this study is part of a larger work that tries to help the Lebanese government, particularly the Ministry of Communication and the Ministry of Public Health. The idea for the study was triggered by government officials early on in the pandemic, around February. They were calling on the public to calm down, not to panic. We have things under control, stop the media frenzy, do not be afraid. All of these messages, of course, health communications experts were totally going crazy on them, and they were not being that this is not the right message to send. right after that, we decided to launch a national survey to pinpoint certain communication and media exposure modes that may help in promoting abidance by COVID-19 prevention measures. I'm going to be presenting today about is this focus on the COVID-19 prevention measures. We defined COVID-19 prevention measures using 6 variables that asked participants how often they avoided crowds, how often they washed their hands with water and soap, stayed at home, avoided shaking hands, avoided touching their face, and covered their cough. Those are the main, that was the main advice at that time. Our study focused only on Lebanon. At that point, actually, the government and the media response led to a very successful containment of COVID-19 in the first phase of the pandemic. And by the first phase, I mean the first 6 months until the Beirut explosion, which I'm sure many of you are familiar with. And that was also, this success was despite a huge economic and political crisis that was going on. So our study was nationally representative of 1,536 adults. Our response rate was about 52%, and our sampling error was about 2.5%. We initiated the survey, the fieldwork, March 27, end of March until April 23rd. And what we examined is the following. We examined 3 matters and their relationship to COVID-19 prevention measures, or abidance by COVID-19 prevention measures. First, we examined the relationship between compliance with COVID-19 prevention measures and exposure to media coverage of COVID-19. And media coverage here, we defined it as exposure to TV and to social media, and we combined them together in one scale. The second thing we examined is the relationship between compliance with COVID-19 prevention measures and exposure to interpersonal communication. And this was the first time anyone has ever studied interpersonal communication in a pandemic context. We defined interpersonal communication as exposure to discussions with family, friends, and colleagues about COVID-19. The third thing we tested is fear and perceived knowledge. And our hypothesis with that fear was that fear and perceived knowledge mediated the relationship between media exposure and compliance with COVID-19 prevention measures. And this was our main focus because we wanted the government, we wanted media institutions, we wanted the media and promote a message that this is a scary situation, a scary virus, a scary disease, and not to tell people to tone it down. So we measured perceived knowledge by asking participants to rate their agreement or disagreement with 2 statements. First statement, I'm knowledgeable about coronavirus, and the second statement, if someone asks me about coronavirus, I have enough information to inform them about the subject. And here perceived knowledge is very important as opposed to actual knowledge, because previous studies have established a good relationship between it and with compliance. Because it creates a sense of self-efficacy, a sense of confidence in their knowledge about the disease. We measured fear by asking participants to rate their agreement or disagreement with 2 statements. The first one, the thought of coronavirus makes me feel scared. And the second one, I am afraid that someone in my family may get sick from coronavirus. We also accounted for some demographic variables, including age, gender, and education. But the most important and the most one that we were interested in was whether participants had undergone any media literacy training. Media literacy is an emerging pedagogical movement that believes everyone in society should learn about media effects and build critical skills and strong understanding about digital and media production. So I'll jump now to the findings. When it comes to media exposure, and again, media exposure measured as TV exposure and social media exposure combined. First, we found that media exposure to COVID-19 news positively related to complying with prevention measures, especially for people younger than 30 and those with a university education. Second, media exposure also positively related to perceived knowledge about COVID-19, especially for women. for people younger than 30, for those with no university education, and for those with no media literacy training. Third, media exposure also positively related to fear of COVID-19, especially for people older than 30, those with a university education, and those with no media literacy training. So when it came to interpersonal communication, we actually found no significant relationship between exposure to COVID-19 information through interpersonal communication and any of the three variables, whether it was fear, perceived knowledge, or compliance with the COVID-19 prevention measures. So lastly, we found that perceived knowledge and fear about COVID-19, fear from COVID-19 mediated the relationship between media exposure and taking prevention measures. And that was especially for women. And this was a very strong message that we sent to the government. Additionally, we found prevention behavior was more likely to be affected by perceived knowledge for people who have undergone media literacy training. So comparing our findings here to the literature, when it comes to media exposure, it was quite consistent with the literature that perceived knowledge and fear mediated the effect of media exposure to news about the disease. So here our recommendation was to the Lebanese government to continue to use messages that promoted fear and messages that promoted a strong sense of self-efficacy, which comes with perceived knowledge. However, our study was not consistent with the literature when it comes to interpersonal communication. Although this is the first study that has engaged interpersonal communications in a pandemic context, previous research has established a significant role for interpersonal communication in helping achieve the goals of health communication campaigns, but this has not been applied to pandemics previously, nor to emerging diseases, where the healthcare professional is not part of the interpersonal communication campaign. Just to explain here very quickly, interpersonal communication is often used in health communication campaigns where the healthcare expert is part of the interpersonal communication transaction. This was not possible in this pandemic due to the high risk of infection. The second reason why this didn't work with interpersonal communication, because the knowledge was emerging, evolving as we go, whereas in the past, interpersonal communication has been used for diseases where the knowledge became stabilized and constant. So for Lebanon, our findings demonstrated that despite numerous economic and political obstacles that faced the country, the consistent coverage of independent media and the coherent governmental and strategic communication campaign played a crucial role in influencing people's behavior and in ultimately mitigating the pandemic. In other words, even in a dysfunctional state like Lebanon, and in a disastrous mode where we had economic collapse, currency collapse, political turmoil, uprising, a strong communication strategy still carried the day. Two more points here to highlight when it comes to gender regarding our finding. The mediation of perceived knowledge and fear was more effective for women. And we think this may partially explain many reports about higher levels of morbidity and mortality among men, which may be attributed to economic, cultural, and lifestyle factors. First, men globally are the main breadwinners, despite decades of women's advancement in the workplace. So this makes it more difficult for them to stay at home, for example. So the abidance and the compliance was not there. Second, in most cultures, indeed in Lebanon, men are socialized to suppress feelings, especially feelings of fear. And third, partially due to this machismo factor, men are more likely to engage in unhealthy behavior that put them at high risk categories. And lastly, when it comes to media literacy, our findings show that media literacy can play a major role in mitigating future pandemics. Media literacy can especially boost confidence in individuals' perceived knowledge because it aims to develop people's skills about media consumption and production. Media literacy usually trains on evaluating the credibility of online content, managing information overload, and verifying information in various media. Studies in the past have demonstrated that media literacy is effective in various healthcare interventions, especially when applied over a long period of time, for instance, in schools and universities. So our final recommendation was to generalize media literacy education in schools and universities, and to inject in those curricula, in those media literacy curricula, some health literacy modules. And that's all I have to present today. Thank you.
Thank you so much, Dr. Mekki. That was really a great update about your research. Very important research, complemented our topic extremely well. Please stay tuned for some questions here. Stay online for the Q&A session. Moving on to our final update on the front lines. This is an update from Denmark by Dr. Lotte Hogberg. Dr. Lotte Hogberg is a medical toxicologist and is a faculty in the Department of Anesthesiology and at the Danish Poison Information Center in Copenhagen, Denmark. And she's going to give us an update about the evolving, emerging situation in Denmark related to the mink animal population. Dr. Lotte?
Yes, thank you. And thank you for letting me join in on such a short notice. I know who's shifting.
We are
the
going to move your slides.
Thank you. I'm not putting my video on as I have a not very good connection, so I have to just keep the voice on. Okay, good. Okay, the mink in Denmark, we have 17 million mink in Denmark, and they are animal production animal. They're used for their fur only. We don't eat mink. We just use the fur. It's a quite a big post on the Danish budget. Yeah, the next slide, please. The timeline in the mink situation in Denmark actually started in June, the 17th of June, where one farm, animals in one farm was tested positive for COVID-19. And this evolved very slowly in the beginning. After 3 days, in two farms they found infected animals, and on July 1st, 3 farms, and then it was kind of quiet until later on, until in the beginning of October, week 40, week 34, where suddenly more farms began to have infected animals. By October 1st, it was decided to call infected minks in mink farms, but also in farms with only healthy animals located within a radius of 7.8 kilometers of an infected farm. So that was around 2 million animals that were supposed to be culled. On October 26th, the number of infected farms reached 149, and this number continued to increase. And on November 4th, it was decided that all minks, all 17 million animals in Denmark should be culled. Today, this morning at I think it was 1 o'clock this afternoon Danish time. Now it's 10 o'clock p.m. 237 farms had infected animals, and 2.5 hours later, this number was increased to 243. So all the figures that I use in this presentation are from the health authorities in Denmark. The next slide, please. This map shows the place of the first farm with infected mink. That's the blue dot up in the northern part of Jutland, and also the spread to other parts of Jutland. All the red areas are areas in Denmark where we have the infected mink, and the green areas are areas where we have mink farms but with no infected mink, as by today, this afternoon. The total number of mink farms are 1,140, and and they are all over the country. The next slide, please. Yesterday, the health authorities posted three reasons for concern. The first is that it has not been possible to stop the spread between the mink farms, despite a huge effort both from farmers and from the health and food authorities, but also because the virus spread from mink farms to employees and in the community are observed. And then there is a concern in relation to the virus mutation. And regarding the spread between the mink farms and from mink farms to human, it has contributed to a very high infection rates in the communities and in the areas with the many infected mink farms. And the concern with in relation to the virus mutation is that it may affect the efficacy of the spike-based COVID-19 vaccines that are being developed these days, and the protective effect of antibodies in previously infected individuals. The next slide, please. And virus mutation was exactly what happened here. The mutation that happened in the mink was identified as a spike protein mutation, and it was named cluster 5. The transmission from the mutated virus to humans has been confirmed, and this variant shows signs of being less sensitive to antibodies from humans or individuals who have recently suffered from COVID-19 infection. And this is the cause to the decision to cull all minks in Denmark that the government decided on November 4th, and also sent or shared this information with the early warning response system in WHO, and they posted an alert on November 6th that there was this issue with the mutation, and at that time 214 human cases of positive COVID-19 was identified with COVID variant associated with mink farms. And in these 214 cases, 12 cases had this unique variant, this cluster 5 variant. However, these 214 human cases is only 17% of the positive COVID-19 patients in the region. This means that 83% of COVID-19 positive tests has not yet been analyzed for the mink variants. And these analytical procedures are being proceeded these days, and it's relatively time consuming, so it takes time. But we will expect that within these 83% that there will be more cases of both the mink variants, but also this specific this unique variant. The next slide. On November 4th, the northern Jutland was locked down, but only the municipalities with the highest infection numbers and where the cluster 5 was identified has been locked down. This is why the red regions on the map you see in this slide are smaller than the other map, where a bigger area of Jutland was red. But the restrictions in the northern part of Jutland is that the citizens, they are encouraged to stay within their own municipal borders or boundaries, and all restaurants, cafes, pubs are closed. Public transport is suspended. Students, lower grades and also university students are receiving distance learning. Public and private workplaces, they have to work from home, except if they do critical functions like healthcare, food supply, or other supply. All cultural activities are set, sport activities are closed down, and assemblies are restricted to very few persons. The next slide, please. So as you have probably seen in the news, or I'm sure you have, otherwise I wouldn't have been here and been invited to do this small talk, short talk. The call has already started, and it was decided to be completed by November 16th. Today at 2 p.m. Danish time, mink from 188 farms with the COVID positive minks are culled, and they use either carbon dioxide in the bigger farms to euthanize the animals, or in smaller farms they actually use carbon monoxide, as they use small mobile boxes that are connected to a diesel engine. All the dead animals are buried, at least at the moment, as you see in this horrible picture. But it might be that they will be burned because there's a huge number of animals. It's 17 million animals. And the next slide. Because there is a but, you have probably seen in your local news that this the mink cull puts Denmark's government in a legal pinch, as there's no justification for giving the orders to cull all minks, both the sick and the healthy animals. Actually, only the sick animals are allowed to be put down, to be culled, and plus, of course, the animals in the mink farms located within a radius of 7.8 kilometers of an infected farm, as it was in the beginning of October. And you can say it has caused stormy weather in political waters in Denmark, and a lot of confusion in the municipality, in the public, as well as sadness with the affected farmers, as their livelihood has gone from one day to the other. Things are developing and changing very fast, and these data that I showed you here will probably already be different, because it's 6 hours since I made the slides. So, but thank you.
Well, this was a terrifying situation, Dr. Lotta. Thank you for sharing this with us. I hope this gets under control very rapidly. It just really reinforces what we can do to prevent the transmission, and what we can do through health communication and abiding by these public health recommendations. I will now turn it over to Dr. Chuck McKay for the Q&A. I'm also going to ask the viewers, with all apologies, just to stick around till 4:30. We're going to extend the Q&A a little bit just to go through the large number of questions. Thank you.
All right. Well, thank you all for hanging in here a little extra. My name is Charles McKay, past president of the American College of Medical Toxicology, and have a few questions I'd like to address to Dr. Fisher, and then if we have time, maybe one or two for Drs. Melke and Huckabud. Let me start off with this one. When many Americans don't trust information from the CDC or the World Health Organization at this point, where should we direct those people to try to provide accurate information? Or is there a way to easily do that, I guess, particularly in a time-constrained or attention-constrained setting?
That is an enormous gap right now. And I think one of the most troubling effects of the loss of trust in CDC and WHO authorities. There are several professional associations, as well as universities, that are doing hard work to try and supply that information that can be used either by the public or by healthcare professionals. For example, the Infectious Diseases Society of America, the American Academy of Pediatrics. My examples are very US-centric, but there are certainly professional associations worldwide that are sharing information, and universities that are trying to present recommendations, again, for the public and for experts. That said, CDC and WHO are still solid sources. And so we eventually have to figure out how to reestablish that trust so that people aren't forced to shop for different sources, which can, again, just lead to, it's very time consuming, and it requires people to be very dedicated to keep looking for that information.
So if you're going to take the time to go find sources, then you have to see if you can trust them and all. One listener has written in it, and specifically, I guess, regarding their own organization, but related to providing accurate information. They say that their particular organization doesn't either have or use social media, so they're not apparently able to get the message out even to their own employees. So if they're limited to putting static information up on a website or something, would you recommend the same kind of thing as far as a resource going to universities, CDC, WHO?
Yes, and I think that the key here is social media allows for quick responses and quick spreading of information, but online platforms like a website are often, they endure to a degree, and they can be places where messages can be added and built, and a clear endorsement by a trusted voice can go a long way toward helping people understand what sources are reliable. So even if you don't have social media to reach out, you can do operational risk communications if you need to reach your own personnel through email, through WhatsApp, through other distributed measures. And a website can be a great place to post information. If you need to update more frequently, link to a site, like, for example, the Johns Hopkins site, that is updated on a regular basis.
And somebody has commented that part of the problem with our communication is the politicization of it, and you've covered that in some of your talk. For those people who are talking as experts and building the foundation for their opinion rather than starting with their opinion first, but they disagree or interpret the data differently, their question is how can we change how we engage with each other as experts when there are disagreements about the merits of certain treatments? At the same time, this loss of public trust that you've mentioned. How do we foster public trust while we're debating the points ourselves?
I think that's a great question. I've been asked in the past by reporters, actually, in the past few weeks, often, how can scientists disagree? And the answer that we're A, not monolithic, and B, science is a very broad umbrella. We come with vastly different disciplines and experiences that influence how we interpret the evidence in front of us. I think being frank about the nature of scientific discussion, saying as we put these arguments out, we all acknowledge that there is a process for evaluating the evidence, testing our assumptions, and being clear. One of the big tenets of risk communications is be clear about what you know, and also be clear about what you don't know. It's better and more defensible in the long run, and preserves trust better to say, this is the evidence we have now. Based on it, this is what we understand, and this is what we believe. But we keep revisiting that evidence. We're learning more all the time. Here's what we don't know, and here's where we may have to change as we go along. Laying that foundation and expectation makes it seem less like a battle between reputations or that science has backed down, and makes it more clear that this is the process. We get more information and we evaluate it, and we keep building on what we know.
Well, based on that, and certainly that's a key tenet of risk communication, is I don't know now, I will get back to you, or coming back, but there's a lot of impatience and all. And the one person had questioned, just news just out these last couple of days, and as is asked if you could comment on the total silence from the CDC in response to the Pfizer vaccine reported rate of efficacy of greater than 90%. They wonder, is this effective risk communication with regards to the current COVID surge when it's unlikely that widespread distribution will occur for months still?
I think in this case, this is actually, there have been a lot of issues with the way CDC has presented and had to then, and either not had to, has presented and retracted various statements that have helped erode trust in what CDC is sharing and created concerns that there's a political motivation rather than being driven solely by public health. Not commenting on a promising but very incomplete vaccine study is actually right now not a surprising action, and it would help. Again, there's a lot of public comment. Most of the comment from experts about the new Pfizer results is cautious optimism that is great news. The results so far are very promising. The numbers so far are very small. We need to see the study finished out so that we can understand both the protection it offers and the risks. So CDC not commenting is actually reasonable. That's not CDC's job to comment on the evaluation of a vaccine. There are other federal agencies that oversee that, including the FDA. And CDC is actually better positioned not commenting on a partially finished study, except possibly to say, good news, cautious optimism, wait until we learn more.
That's an important point, right? You don't want to be commenting outside your lane, especially if you're stepping on the toes of responsible agencies or entities. You know, the information you presented in terms of electronic media, social media, print media, kind of matches up or has to stand up against Dr. Melke's work. And I guess I would ask both of you to just comment on the idea that a lot of what I read in the newspaper is often the headline that is not at all supported by something that's in the next to last paragraph, or where the whole headline tends to get, I guess, countered by what the data actually would suggest. So I was a little bit surprised to see that print media was taken as a good source of information for people's perceived knowledge. I could understand the perceived fear part, or the fear part that Dr. Melke had mentioned. So the question is there any objective evidence or questions in Dr. Melke in your study where objective questions that would allow you as a researcher to indicate whether people's perceived knowledge had a good factual underpinning, I guess? In other words, a factual question about the virus that people could respond to, or was this just a survey of perceptions?
No, actually, we also had a series of questions that measured actual knowledge at the time, and that will be published in a separate study. We're still in the process of crunching the data on that. There's a third study that we've just submitted a couple of weeks ago that focuses on misinformation, that is from the same data set. But preliminary results are in the white paper on our website, and if I'm remembering correctly, there is a correlation between perceived knowledge and actual knowledge. I don't remember the breakdown between demographics, but it's very interesting you bring up the issue of journalists and how they cover stories. We have a huge problem, both locally in Lebanon and globally, when it comes to journalism and health communication. There's a new movement that promotes health journalism, scientific journalism, educational journalism that explains exactly what Julie was talking about, the concept of science, the concept of accumulation of knowledge, how knowledge continues to evolve. It's not a black and white thing. There's always conflicts between different methods, different researchers, different schools of knowledge. And this is something we're trying to inject in our curricula as journalism educators. In fact, actually, the last 2 days since Pfizer announced this 90% vaccine, all I've been doing in Lebanon is fielding questions from the media. What does 90% mean? How do you get 90%? How do you measure 90%? How do you calculate 90%? There's a large gap of knowledge among journalists when it comes to science, understanding science. And this has actually been quite a lovely piece of evidence for me in front of my administration, because a lot of my students complain about taking research methods and they hate it because it's quite a heavy course. Journalists don't want to learn quantitative methods. So there it is. You need to learn science, you need to learn research methods, not to become researchers, but to at least understand the logic behind science, behind research, how it works. So one day you can report on it accurately and not mislead people and get people killed, basically.
So any comments, Dr. Fisher?
No, I think that that's exactly right. And I think the other issue is, again, what can scientists do? So I'm actually a microbiologist by training and not a risk communicator by training. So I look to researchers like Dr. Melke to help understand how we can do our jobs more effectively communicating. And I think part of that is when we say a statistic, don't assume that that conveys real meaning or real risk for a general audience. We have to put it into some sort of context. Expressing risk and expressing uncertainty are incredibly difficult disciplines. And scientists also have to learn how to say, when I tell you that this reduces community transmission by this percent. What is community transmission? Let me explain. What is that percentage? How did I get that number? Let me explain. Reporters will take the information that we give them, or they will fill in the gaps with conjecture. So it's also up to us to learn stronger communication skills and not to assume that just putting a fact out is the same as communicating.
Really important. We're getting to the end, and there are some more questions coming in. I do want to ask a question of Dr. Lottie. Let me just respond to the questions that are coming up about the mask by asking people when this recording comes back out, really take a look at the slide Dr. Fisher presented about some of the problems with respiratory transmission and the idea that an answer isn't necessarily wrong if the community transmission rate, for example, changes drastically between when messages are being passed out. And similar to that, the CDC has been reassuring regarding the lack of animal, certainly pet-based transmission. And we have a couple of questions coming in about the mink issue, particularly one that I think, as best I can translate it, indicates that, what about the concern about pets? And is there any likelihood that there's animal to human transmission that now will also involve pets? So I don't know, Lottie, if you have any information to address that at this point.
Well, I have to answer very shortly because I'm on call at the Poison Center.
Well, we appreciate it.
But I mean, we don't have the mink as pets, and there are a few cases where dogs and cats have tested positive, but it's not a huge problem. It is the mink and the mutation in the mink that cause a bigger problem in Denmark.
All right.
I could add to that just very, very briefly.
Sure.
Sorry for my other hat. We use ferrets in the laboratory as a model for many respiratory diseases, including other coronaviruses, for understanding transmission. So ferrets and minks are of the same family. It is not particularly shocking that they can be infected. It's just something we didn't foresee as a real risk in terms of amplifying the disease through an animal reservoir.
All right, well, we could talk more about the nasal epithelium, but let's not go there right now. Dr. Wax, let me turn this back over to you. I thank our presenters once again, and particularly Lottie for hanging in there late into the evening, and Dr. Melke as well. Dr. Wax?
Great, well, thank you very much. And we'll just go to the next slide if we could. And just remind everyone that we'll be continuing the webinar series next week. We have a very important webinar on testing and treatment of the 2020-2021 seasonal influenza during the COVID-19 pandemic. So we're fortunate enough to have Dr. Tim Uricki, who's the Chief Medical Officer of the Influenza Division of the National Center for Immunization and Respiratory Diseases at CDC. So very important and timely talk. There'll be actually next Friday, November 20th at 3 p.m. We've done up until now all Wednesday webinars, but because of some scheduling issues, his webinar will be on Friday, November 20th at 3 p.m. Next slide. And after the Thanksgiving break in December, we'll be continuing with two additional webinars. The first is on disinfection and sterilization. This is part of a mini series on disinfection that we'll be bringing to you all with support from ATSDR CDC. And this will be the initial webinar on disinfection, a primer with a focus on the use in healthcare facilities. And that will be followed by the last webinar of 2020 on pregnancy during COVID-19. And the chair of the Department of Gynecology and Obstetrics at Emory Healthcare, Dr. Denise Jameson will be giving that talk. Next slide. So finally, all our prior webinars and upcoming webinars can be found in our prospectus, which you can download from our website as seen at the URL. I'd like to thank again our speakers for fascinating talks today, very important and timely. And everyone have a good day.